Good afternoon. On behalf of the director of the Ramón Areces Foundation, Mr. Raimundo Pérez Hernández, let me give you a warm welcome to the Ramón Areces Foundation and to this conference. Let me introduce myself. My name is Daniel Santín. I'm professor of economics at the Complutense University of Madrid, and I'm also in charge of organizing and coordinating some of the activities that are sponsored by the foundation. So this event will be in English. However, since one of the priorities of this foundation is to foster the use of the Spanish language in science, let me do part of this introduction in Spanish. Bien, en primer lugar,
first of all, I'd like to thank all of you for coming to the foundation to enjoy this conference entitled The Economy of Health in an Aging Society, World Trends, which will be delivered by the Professor Alistair McGuire from the London School of Economics. Thank you so much, Professor, for accepting this invitation that I'm sure we'll all enjoy. Secondly, I'd like to thank Andrés Rodríguez Cose, who is also working in the London School of Economics, one of the most brilliant economists that we have in Spain, who is going to act as moderator. Thank you so much for your commitment and effort for these seminars from the London School of Economics can be possible. Thank you, Andres, for your hard work. Thank you to the whole team, Adam, John, Christian. I need to thank you all for this ongoing effort to bring these excellent speakers. You always a spearhead. You always bring the most interesting subjects so that we can enjoy these very interesting conferences. And in the headquarters of the foundation, we're holding the first master class. It's a 3-day master class. It's called The Economics of Healthcare in an Aging Society, Global Trends in the Strategic Alliance that the LSE has with the Ramón Areces Foundation. And thirdly, for those of you who are not familiarized with the activities or what the Ramón Areces Foundation does, let me tell you that the foundation aim is to promote excellent science in Spain. And for that, the foundation has 3 main areas: science, material science, humanities, and social sciences. And we have different programs, some of them postgraduate. If you know someone who would like to do their master's or PhD in one of the best universities in the world, they can opt to do that. And the foundation has strategic alliances with some of the most important research centers in the world. For example, the MIT, Oxford, or the London School of Economics. And lastly, the foundation carries out in these 3 main areas many conferences, very valuable conferences, so that excellent science can connect with civil society. So that's all from me. We're going to enjoy the conference. Before that, please do explore all the contents of our foundation YouTube channel. Andres, you have the floor. Thank you so much, Daniel, for your introduction. My name is Andrés Rodríguez Foses. I'm a professor at the London School of Economics, where I'm director of a Cañada Center. And for me, it is a great pleasure to be here today to introduce the conference of Professor Alistair McGuire, especially because of the strategic collaboration we have between the LSE and the Areces Foundation. It's already been 13 years of collaboration in an agreement which I think is very important for us because it contributes very clearly for us to, on the one hand, make the most of the research that is being carried out at the LSE, but also to know and interact in the master classes with scientists, managers, and top-notch professionals in Spain who are, thanks to the selection that the foundation does for these master classes. we hope they will last for many years. So I'd like to thank the foundation, represented by Raimundo, Daniel, Miguel, and the whole team. Thank you for collaborating with us. I'm going to switch into English now so that Professor can follow me.
Today we are living in a world of change, in a world of radical change. A world that is in some ways better, but also more challenging than what we have witnessed before. And one of the biggest challenges is that of the change in demographics. We are in an aging world because across the world we're seeing, on the one hand, is a decline in fertility. There are less and less babies across the world. Last year, South Korea reached the lowest fertility rate ever recorded by a society in history, 0.72 children per fertile woman, which means they were at levels of 1/3 of the expected reproduction rate. The numbers have increased slightly this year from 0.7 to 0.75. Having said that, we're still at 1/3, so nothing has changed. And when we're talking about South Korea, this can be applied to mostly every developed society and increasingly many emerging societies across the world. On top of that, and this is the good news, we're living longer. Life expectancy everywhere has grown, and it has grown exponentially. And we're living better lives. But longer lives, better lives, implies challenges for the type of diseases that we are encountering, the types of, let's say, ways in which we deal with those diseases, the type of specialisms that we need, and of course, the type of health systems that are required and how those health systems need to work and need to be paid for. So today, Alistair McGuire, who is the head of department and a professor of health economics at the Department of Health Economics at the LSE, is going to be talking about the economy of health in a society that's aging, and he's going to do it from a comparative perspective, taking an overall view at what's happening in the world. I can think of no one who is better prepared to talk about this. Alistair has got a very long trajectory, having been at the LSE for, I think, probably longer than I've been, and I've been there for 30 years, but before that in places like Oxford. And he's also one of the most prolific, most respected, and most cited researchers in our institution. So I leave you in the very able and very capable hands of Alistair, and please start preparing your questions, because we hope that there's going to be a very interesting and fruitful debate at the end of his intervention. Thank you very much.
Okay, thank you very much, Andres, for that kind introduction. And thank you to the Foundation, Mr. Fernandez, as the President, for the invitation today and for the invitation to run the masterclass, which I thoroughly enjoyed, and it's a pleasure to be here. So thank you very much for the invite. Let me just see if I can work the technology. Yeah. Oh. Yeah. Okay, so I'm going to talk for approximately 45, 50 minutes. I've got quite a lot to say, so I'm going to say it rather quickly, so I hope you follow me. But to help you, I just want to give an outline of my talk and what I'm going to talk about. As Andreas said, I'm going to speak largely about global trends, but trends in healthcare associated with the wealthier countries in the world. And I'm going to be particularly interested in talking about why healthcare expenditure is rising, because that, after all, is what most people who are in control of the public finances, in particular, are interested in, and the politicians are interested in. And it's the politicians, we can't get away from the fact that healthcare is a political commodity as well, and it's the politicians who, as you'll see from my talk, who are are partly responsible for the underlying healthcare expenditure. What I'm going to outline, however, is that the expenditure is increasing partly because as countries get wealthier, obviously as we get richer, we want to live longer, and we therefore want to spend more on healthcare to lengthen our lives. But new technology is actually the most important driver of healthcare expenditure, and I'll come back to that later in the talk. But also widening insurance coverage, and the widening of insurance coverage goes hand in hand with increased technology, because new technology tends to add to expenditure rather than detract from it in this sector. And then on top of that, we have, as Andreas has pointed out, an aging population, but the aging population has an impact on the healthcare sector, which is directly not large, but as I hope to convince you, it's indirectly going to play a very large role within the funding of healthcare over time. And of course, one of the bigger problems is that as we get an elderly population, an aging population, the labour supply shrinks itself, and I'll say more about that as well. I want to preface all of this by saying that actually our healthcare expenditure, even in the wealthier countries of the world, has been a rather recent phenomena. Really, healthcare expenditure's only taken off since the early 20th century. So within the time frame of my grandfather, for example, we've seen a huge rise in healthcare expenditure, which was publicly funded from the beginning of the 20th century, with social insurance for working population initially, but then in the wealthier countries, that's rolled out as social insurance within the general population. And I'll say why social insurance is important rather than private insurance as we go through. Technology has always driven expenditure, but the real technology gains, of course, have come after the Second World War. Antibiotics were discovered just prior to the Second World War, but really the new technologies, which are the driving force in healthcare expenditure, have really only come to fruition relatively recently. So, and I'll say a bit more about technology in terms of how it affects, even when the unit costs for the introduction of new treatments are falling, how it affects overall expenditure. I also want to say that really in thinking about healthcare, you have to think about healthcare as an insurance benefit. The delivery and production of healthcare is really the outcome of insuring the population for unexpected costs which arise from treatment costs in their lifetime. So insurance is fundamental to the delivery of healthcare. And indeed, social insurance is really what we're talking about. And if you think about the healthcare sector, as an economist, you should think about the healthcare sector as really an insurance sector where the physicians and the healthcare providers are really providing the healthcare benefits from that insurance. So we're talking about insurance right from the get-go. In this slide, we've got the amount of healthcare expenditure as a proportion of GDP from on the y-axis, on the vertical axis, across a timeline running from 1970s for the wealthier countries in the world, the OECD countries. You can see two things here. One is that the general trend has been rising linearly over time. And if we went back before the 70s, that would be true as well. So we've seen a linear increase, pretty much linear increase in healthcare expenditure as a percentage of national income, gross domestic product. The USA is a huge outlier here. I've stopped this at 2018 for the obvious reason that we see a blip in healthcare expenditure with COVID. I'll come back to that during the talk. But the USA is an outlier here. It's spending almost now, it's up to 18% of its GDP. Almost $1 in $5 of its national income is being spent on healthcare in the US, but it is an outlier. Spain's doing not badly in terms of overall percentage of GDP, but if we move to look at the healthcare expenditure per capita, so the y-axis now has the healthcare expenditure per person in each of these countries, again since 1970. When you take the population into account, Spain kind of becomes a more middling spending country than a high spender as proportion of GDP itself. We can see Spain in here. Again, I've widened this out to be a bit more incorporative of other countries in the world. The biggest insurance revolutions, for example, the biggest increase in the coverage of populations for healthcare has taken place since 2016 in China and 2017 in India. So the most populous countries in the world have moved towards some sort of social insurance coverage for the populations. And you can see that India, for example, is spending not very much, but of course, taking account of the prices in India, it's probably quite basic but good coverage that's beginning to be introduced across that country. Spain's, as I said, a sort of middling country here. And once you take account of its population in terms of looking at healthcare expenditure per capita, it's slightly below the OECD average in terms of its expenditure. But again, it has been rising over time, okay? Now, the issue is, of course, why has it been rising over time? What's happening? What's driving this rise in healthcare expenditure? So here we've got healthcare expenditure on the y-axis per capita, per head of population, and it's denominated in terms of dollars, so the exchange rate's dollars, but it's exchange rates which account for differential prices across different countries. These dollar prices are purchasing parity prices, so they account for example, the fact that a cup of coffee is much more expensive now in the USA than it is in Spain, right? So it's trying to take account of the relative prices. So we've got exchange rates in dollars, taking account of the relative prices, and we've got the high-income countries represented by each of these dots on the graph, which maps healthcare expenditure on the y-axis against GDP on the x-axis. And you can see if we drew a line of best fit through these curves, that line would essentially say that 90% of the variation in healthcare expenditure per capita is associated with the income level per capita in a country. In other words, whilst each of these countries may have different sorts of financing arrangements and different sorts of provision of healthcare and delivery of healthcare, the GDP per capita itself seems to be driving some of the variation in healthcare, quite a lot of the variation, 90% of the variation in healthcare expenditure across these countries, which is a kind of remarkable finding if you think about it, because it's saying regardless of the type of healthcare system you've got, it's income which is providing some of the drive towards how much a country spends on healthcare expenditure. It actually led to two really fairly crude but important health policy decisions. The first health policy decision came from the World Bank. The World Bank, as you know, is a bank which lends money from the wealthy countries in the world to the poor countries in the world. And one of the objectives in that lending policy is to increase healthcare and education in countries. And in the early 1980s, an economist called Larry Summers, who was the chief economist at the World Bank, looked at this graph for that year. This is the latest data that we have, but he was looking at the same graph. It had exactly the same pattern. About 90% of the variation in healthcare expenditure per head was accounted for by GDP per head. And he said, well, actually, if we want to improve healthcare and education in poor countries in the world, we just have to make them grow richer. So we'll just give them the money, and as they grow richer, they'll put more money into healthcare. It worked to a certain extent, but then, of course, corruption kicked in, and a lot of the money didn't end up in the places that it was meant to end up in, so it wasn't exactly appropriate as a health policy. The second health policy was in 2008, Tony Blair, who was the Prime Minister of Britain at that point in time, looked at this graph as well and said that he wanted to move the UK, which is now on the line actually in 2022, but in 2008 it was below the line, and he said he wanted to move the UK healthcare expenditure up to the average of the OECD. And so he announced on breakfast television on a Sunday, this is how politicians make policy, he made an announcement on a Sunday breakfast TV show that he was going to increase healthcare expenditure per head such that the UK would be at the average amount for its GDP level. That ultimately meant that we, over an 8-year period in the UK, we doubled healthcare expenditure from 60 billion to 120 billion pounds over an 8-year period. Now, if you think about that, healthcare expenditure, generally about 70% of healthcare expenditure goes on labour costs because it's a very service-orientated industry, it's a very labour-intensive industry. It takes about 8 to 10 years to train a doctor and about 5 to 6 years to train a nurse. So if you're doubling from 60 billion to 120 billion the healthcare expenditure in a country, you're not able to bring in enough workforce. So it led to wages rising without any output rising in the healthcare sector, and also the supply of migrant labor, nurses in particular from Philippines and Indonesia, and doctors from Pakistan and India being dragged into the UK to supply the workforce which was required to eat up that doubling of the resourcing within that country. So policy can be very crude, okay? But it's generated partly by the understanding that as countries get richer, they want to spend more in healthcare. And that's one of the drivers in terms of why healthcare expenditure is going up. We're still getting richer within the wealthier countries in the world, and so we're still seeing an increasing trend in healthcare expenditure across the wealthy countries. But even if we expanded that out to the rest of the globe, again, with current healthcare expenditure per head on the y-axis here, and GDP per capita on the x-axis, you can see that on the y-axis I've transformed the health expenditure so that it's in logarithms, so the distance between $50 and $100 is approximately the same as 5,000 and 10,000 because I've squashed the transformation has squashed the y-axis. But if you transform healthcare expenditure and map it against GDP, you get this linear relationship, almost a constant increase in healthcare expenditure per head as you see an increase in GDP per head. So if you think about that, that's remarkable as well. An almost constant increase in healthcare expenditure per head as GDP per head increases, regardless of the type of healthcare system you've got. So Ethiopia, you can see down here, it's got a markedly different healthcare system from the United States or from Singapore or Japan. Both the financing and the delivery of healthcare is very different. But this graph is telling us that as countries get richer, regardless of anything else, they spend more on healthcare. And it kind of makes intuitive sense. The populations, as they get richer, want to live longer, want to therefore spend more on healthcare. So one of the big drivers is income. And in fact, our studies show, if you look at any economic study which has looked at the precise relationship between the rate of growth in healthcare expenditure and the rate of growth in income. It says essentially that as a country's income grows by 10%, as aggregate income grows by 10%, healthcare expenditure will grow by about 13%. If you want to be technical about it, essentially the proportionate increase in healthcare expenditure relative to a proportionate increase in income, GDP, at a country level, the income elasticity, is greater than 1. As income grows, you're going to put more resources into the healthcare sector. And that's, again, shown in this table for a subgroup of the wealthy countries in the world on the top. This is healthcare expenditure in 5-year blocks in terms of health expenditure growth. So it's the per annum growth within that 5-year block on healthcare in the top of the table at the top. And that's contrasted with the growth rates in national income in the table at the bottom. And the take-home message is essentially that healthcare expenditure generally across all these countries is growing faster than national income. Right? So the healthcare sector is growing faster than the average sector within any country. So healthcare is getting more resources devoted to it than the average sector. Healthcare is a growing, expanding sector. That graph only went up to 2018 as well because of the impact of COVID. Obviously, with the impact of COVID, the darker blue line here on the percentage increase in expenditure on the y-axis mapped against the timeline from 2015 to 2022. You can see that funny things happen, obviously. The darker blue line here is healthcare expenditure growth. This is GDP growth. Obviously, we saw a big hit to GDP growth across the world as we saw lockdowns. But then, even with taking account of the COVID pandemic, we're now seeing a restructuring of healthcare expenditure. So for the past 2 or 3 years, healthcare expenditure per capita has fallen below national income. But the expectation that I have is that that will reassert itself and healthcare expenditure in the future will grow faster than GDP. So I think we'll get back to some form of normality. What do we get for that? Well, partly it's very difficult to measure what we're getting, but as Andreas said, just to put some context in here, we have been seeing life expectancy grow, particularly in middle income and high income countries across the world. However, the rate of growth, according to this Lancet article published last year, the rate of growth is beginning to fall off and has been beginning to fall off in terms of life expectancy at birth, has began to fall off since 2010 across the wealthier countries. And their argument is that that trend is falling off. So we're not seeing as much in terms of the gains in life expectancy as we saw in the past. Spain actually does relatively well here. It has a fairly high level of life expectancy at birth. It's up around 82 years of age, the life expectancy at birth. However, Spain has one of the lowest healthy life expectancies. So if you take account of people living healthy lives, not just living their life, but living it healthily, the healthy life expectancy in Spain is around about 64 years of age. So that's saying that between 64 on average and 82 on average, where the life expectancy is topped out, maxed out, that for roughly those 18 years of life, on average, the average Spaniard is living an unhealthy life. Okay? So life expectancy is still growing, but the trend has flattened off a bit. Healthy life expectancy in a number of countries is falling. And if we then map that against expenditure, so we're always thinking about what the outcome is. It could be life expectancy or healthy life expectancy, which we'd hope is influenced by healthcare. If we map it against expenditure, we've got two graphs here. The first one has, this is for the UK. This is the thousands of pounds which are spent on different types of healthcare. The massive spend is still in the hospital sector, okay? So the hospital sector, this large part of maroon here is the spend on hospital care. The next one is general practitioners in blue, and then drugs, and then capital spend. So the hospital expenditure still dominates the spend, even as we're seeing a growth in healthcare expenditure per capita, hospital spend dominates. The graph over here is for females and males in terms of their per capita spend at different ages. And the first real point I want to make about the aging and the expenditure is if you look at this, most of the spend, I mean, I'm not going to talk very much about long-term care, but most of the spend is associated in, when we're considering aging for the individual, most of the spend is spent in the last 2 years of life. Most of the health care that individuals consume is in the last 2 years of life. Other things that are happening, though, is that we're seeing some increase in expenditure associated with chronic diseases, which I'll come back to in a moment, but the chronic diseases are being treated through the cheaper part of the healthcare sector, general practitioners, and outpatient visits in particular, right? So even although you've got an aging population, life expectancy is growing, so your population's getting older, if you're still spending all of your money in the last 2 years of life, the direct impact of, or the vast majority of your resources in the last 2 years of life through the hospital sector, then the direct impact of the demographic aging process within any country is not having a huge impact on expenditure per se, it's just moving that expenditure out. Instead of being spent in the ages of 85, 86 when people were dying, it's moving it to 87, 88. However, as I said, and of course that then concentrates the spending. It's a fairly old graph, but it still holds that the spending is essentially concentrated in a very small part of the section of the population, right? So the high expenditure is still contained in the last 2 years of life, and in the last 2 years of life, that's when you get the most acute illnesses. So we're still spending most of our healthcare resources in the last 2 years of life through the hospital sector, and they're concentrated in a small percentage of the population. That's quite strange because, as I also said, and again, this is data from Scotland, but it mimics data across Europe, that as we age, we're also, and it was contained in that statement about healthy life expectancy in Spain being only 64 years of age. That's because comorbidities are affecting morbidity, not mortality, but morbidity is affecting the population. And this graph shows essentially the percentage of patients on the y-axis over age groups which have different levels of comorbidity affecting them. So the darker blue at the bottom there is for individuals who have 8 or more comorbidities, 8 or more chronic comorbidities affecting them, compared to the lighter blue, which is just one comorbidity. So we're beginning to see not only life expectancy grow, but as I said, healthy life expectancy being decreased, largely because people are living longer with more comorbidity. On top of which, and that was for Scottish data, but this just says essentially, as the headline says, 40% of people over the age of 65 have at least 2 comorbidities now across this range of countries. The dots are men and women, but that's the proportion on the y-axis for different countries. So on average, that orange histogram in the middle there, on average in Europe, they're living with over 2 comorbidities if they're over 65. And not only that, this graph basically says here's the number of individuals on the y-axis, on the vertical axis here, for males and females, mapped against ages in terms of the number of comorbidities that they have, 1 being the blue bars, 2 being the maroon, going up to more than 5 in the lighter blue. And what the graph is trying to illustrate is that the comorbidities that people have are affecting them younger, right? So comorbidities are affecting more people, but they're also affecting more people at a younger age, right? So we've got life expectancy. Well, first of all, we've got healthcare expenditure increasing in a linear trend. When you map it against GDP, it says that income has some impact upon how much you spend as a country. That's just fairly obvious to my mind. Life expectancy is growing, but at a decreasing rate. Comorbidities are also growing, so the population's getting unhealthier, and it's getting unhealthier at an earlier age. But if you remember 2 or 3 slides ago, I said that most of the healthcare expenditure was still concentrated in the last 2 years of life, so the direct impact of aging in a population is not too great, because these comorbidities are being treated in the cheaper sections of the healthcare sector through general practice and through outpatients, not in the more expensive inpatient sector, right? And here we've got the breakdown of different types of healthcare expenditure, the y-axis here giving the proportions for different countries. Generally speaking, the histograms at the bottom plus the next histogram section up, that gives you the total hospital spend. And as I've said, the end-of-life care is still in the hospital sector. It is in long-term care as well, but I'm not going to talk about long-term care. That's a problem in itself. And it's the most expensive care, which is given to individuals in the last 2 years of life, whereas the multimorbidities tend to be treated in the cheaper sections of the healthcare sector. So aging has an impact, but it doesn't have a massive impact. These graphs all show the same thing. Essentially, on the y-axis, the death rates from different types of disease mapped against time from 1950 up to 2021 for the United States, Spain in the middle, and the UK. And they're all remarkably similar. This line here is the death rates falling from 1950 down to 2020, again in a linear fashion. Now, again, I have to stress that linearity is quite important here. It's saying the rate of fall is constant over time, a constant decline over time, over a 50-year period. And that top one is cardiovascular disease. We've seen a decline in cardiovascular disease, a linear decline in cardiovascular disease over time. Now, I'm old enough to remember the 1970s, up here somewhere, right? People were still smoking. They were still drinking in excess. They weren't doing any jogging. Maybe it's not true in Spain, but it was certainly true in Scotland. They weren't changing their diet. It wasn't behavioral changes that were leading to these initial declines. These declines are coming partly through just improved diet, but mainly through technological change. Beta blockers, ACE inhibitors, getting blood pressures down. And then later on in the 80s, open heart surgery being replaced by angioplasty. And then later still, statins coming in. So a lot of this absolutely tremendous linear decline here in cardiovascular disease is attributable to technology, the use of technology. I'll come back to that in a moment, but look at what's happening to the next. That's not to say, although we've got this decline, cardiovascular disease is still the major killer in these wealthy countries, right? And it's increasingly the major killer across the world. The next line is cancer. The blue line here is cancer. Nothing much happens for about 40 years, and then around 2011, we get the immunotherapy coming in. These are the new drugs which act upon people or with people's immune system to fight cancers. So these immunotherapies, the first one was for skin cancer, introduced in 2011. But the problem is you're relying on individuals' immune system to combine with the immunotherapy to give you a response. So a number of these immunotherapy treatments only have on average, a 20% response rate. In other words, if you give the very expensive drugs to 100 individuals, only 20 of them will respond. They'll respond remarkably well, so that the average, the mean effect is big, but it's really concentrated in 20 out of the 100, okay? And they're very expensive, these drugs. Some of them are up to over $100,000 per year as a treatment. The other diseases are all pretty much flatlined. There's some movement in respiratory disease because of various things happening. But you can see that the actual trend across all of these countries is remarkably similar. Technology diffuses very fast across the Western world, the rich countries of the world at least. And again, the two major killers are still cardiovascular disease and cancer. And it's been suggested in the literature that if we're looking at the rates of growth in healthcare expenditure, remember that first graph I showed you, the first two graphs I showed you were healthcare expenditure growing over time, pretty much in a linear fashion, right? That linear fashion of the expenditure growth, that growth rate, the constant growth rate of healthcare expenditure, a number of studies have said can be attributed 30 to 75% of that growth rate in healthcare expenditure can be attributed to new technologies, the introduction of new technologies and changes in the treatment. So healthcare technology is pretty important to the increase in healthcare expenditure. And I want to talk about three different ways in which that healthcare technology might influence things. Let's take angioplasty, the first technology that I want to concentrate on, as an example. So before, if you had severe angina, before angioplasty came along, you'd open up the sternum. It would be an open operation. You'd then remove part of the vessel which was occluded, stopping the blood flow, and you'd replace it with plastic or with pig or vessel, or even a vessel elsewhere in your leg or somewhere. Angioplasty comes along. It's less invasive. It's a wire up through the groin. They then pump a balloon up to expand the vessel. That gets the blood flow going. They put in a stent, a little a tube, and they might even add in some drugs to that tube. Angioplasty is a third of the cost on average of compared to open heart surgery, but it gives exactly the same clinical benefit, right? So it's a third of the cost, so it's a no-brainer if it gives the same clinical benefit. So angioplasty took over from open heart surgery, and in taking over, it's substituted for open heart surgery with a lower unit cost, but it increased total expenditure because you can operate on more patients. Not only that, it's an interesting subject because the angioplasty is done by cardiologists, the surgery is done by cardiothoracic surgeons. So if you're a cardiothoracic surgeon and you're being replaced by cardiologists, you'd expect the number of cardiothoracic surgeons to go down. In fact, it didn't. It just leveled off. Even although angioplasty is taking over from open heart surgery, there was no change in the cardiothoracic surgeons. Why is that? Because they just started doing something else. So the new technology comes in, it's got a lower unit cost, but it increases total expenditure because you can operate in more patients, so the total expenditure goes up because the volume's gone up, but also the people that should be being replaced just switch and start doing valve surgery. So you get an addition to total expenditure through their switching. The next technology which I'll look at is, this is robotics. So we're seeing a huge rise in surgery, of robotic surgery. It was first introduced for prostatectomy, in fact, cancer of the prostate. This is the volume of robotic surgery. This line's the open prostatectomy. It's replaced initially with the dotted line, which is the laparoscopic prostatectomy, so it's a minimally invasive procedure rather than an open procedure. And then the gray line is the line that shows the increased volume in robotic surgery. Robots cost about $1 million to put in place as a capital investment, and then about $500,000 to maintain them. There is no clinical evidence that robotic surgery is any better than laparoscopic surgery. None at all. So some technology gets put in place even although it's not improving the clinical benefit, right? And that's certainly what's happening with robots, and they're rolling out not only across prostatectomy, but across a whole range of diseases now. The third technology I want to talk about is these immunotherapies. They're very expensive. The R&D costs are high. The R&D costs are in the millions here. So here's Riloxabib. That's over $1 billion for its R&D costs. But you can see that the R&D costs generally are recovered. The R&D costs are for these individual immunotherapy drugs in the blue, darker blue, but the sales are in the lighter blue. So the R&D costs are generally recovered, and recovered at a much higher rate. So the high revenue is reflecting their high prices. But what's interesting about all of this is that that's against the background where the number of new drugs, which is the histogram here, the number of new drugs which go through the Federal Drug Administration, FDA, regulator in the United States over 1991 to 2003, the number of new novel drugs are increasing in cost in terms of bringing their cost to the market in such a way that if we plot the number of new drugs by the cost, the R&D cost over time, we see that the productivity of the pharmaceutical agents, the new pharmaceutical agents, is falling off quite rapidly. So we're seeing a big change in immunotherapy drugs coming through, only having response rates of about 20%. The R&D costs are going up. They are recovering their R&D costs, but the number of new drugs coming through to the market is falling off, whereas the R&D costs are going up, right? So the productivity generally is going down. So technology has been said to be the main driver of healthcare expenditure, because it either drops unit costs and increases total volume, or it's just not effective compared to what's currently being done, or the productivity drops off because the expenditure on R&D is so high. All healthcare, as I said right at the beginning, is about insurance. If we were leaving the healthcare expenditure to private insurance, then the price of that private insurance would be based on an actuarial calculation. It would be based on the idea that a premium that I charge as an insurer would be based on this probability of becoming ill, P, multiplied by the treatment cost, this euro sign, of the expected cost of the treatment, plus some cost of doing business, right? And that would be how the private insurer should work out your premium. But of course, as people get older, the probability of getting as we are living in an aging society, as we get older, the probability of us becoming ill gets closer to 1. So then the private insurance market doesn't evolve because the premium would merely be covering the cost of the treatment, and there'd be nobody purchasing private insurance. So for that reason alone, the idea that the probability in this actuarial calculation gets close to 1 as we get more elderly, for that reason alone, social insurance takes over from private insurance. So to my mind, as an economist, it's no surprise that we're seeing increasing public expenditure in healthcare, because as the probability gets closer to 1, the private market isn't going to cover you. Now, there are other problems, but that's the main problem, and that's the main reason why in high-income countries, medium-income countries, and even in low-income countries, we're seeing the public sector pick up more and more of the cost of healthcare. So social insurance, funded by public expenditure for good economic reasons, replaces private insurance to give universal healthcare coverage, especially in an aging society. Where does it get the money to do this? Well, the two ways to get money to fund any public service is through taxation, first of all. And look at this taxation on this y-axis. I've only put 20% of GDP or 40% showing the amount of national income which is covered by the tax base in any country, okay? And if I squash this y-axis down, basically you can see it flatlining, right? It's round about just under 40% of national income is really attributed to the tax that's raised in any country. And that's partly because, especially these days, not many people like paying taxes. Who in this audience likes paying taxes, apart from me? Very few hands went up. I only saw my own, right? So if you're moving insurance for healthcare out of the private sector into the social sector, so it's publicly funded, you can either fund it through taxation, along with all the other stuff, or you can fund it through, debt, public debt. And public debt has been growing massively across the world. And within Spain in particular, your public debt is rising faster than most other rich countries, in such a way that it's reflecting that nowadays investors do not think that you're a good purchase in terms of the rate of return you're going to get on your public debt. The bond rate, in other words, has fallen down from a high of about 10% in the 1990s down to 2% in this last few years. So you can, going the wrong way, sorry. You can fund the movement of healthcare expenditure through the public purse, either through taxes or public debt. Your public debt's rising, so it gets harder and harder to raise more public debt, and nobody likes paying taxes. And the big impact that the aging population is going to have on healthcare is, like the rest of Europe, Spain's on the right-hand side here. These are the numbers of your population on the y-axis here, mapped against the years, the time trend. And the two areas you should concentrate on are these, aged 25 to 64 and the over 65s. The 25 to 64 are essentially your working population, and most taxes still come from income tax. So your working population becomes the real driver for the revenue to fund your public expenditure in the two big areas that are increasing with an aging population, healthcare and pensions, and the over 65s is growing. So by 2040, you can see that your tax base is really shrinking in Spain. The number of individuals in your population who are going to be paying taxes, even though they don't like paying more taxes, just keeping taxes at the level that you've got them at, is going to shrink. And the demands on these public expenditures is rising because pension and healthcare expenditure is rising, because they're getting an elderly population. This graph says pretty much the same. Here's somebody's life cycle across the amount spent in the UK, but it's no different across the rest of Europe. This big hump is your tax base, your working population, and all the spend is on basically healthcare, and some of this welfare is pensions. Essentially, the state is a big redistributive tool which is moving the tax revenues from the working population to the elderly through pensions and healthcare. And yet the percentage, the proportion of your working population is shrinking as the proportion of your elderly grows. If most of your public expenditure is funded by tax, or it has to then be funded by public debt, and public debt is rising to such an extent it's almost becoming unserviceable, nobody wants to raise taxes, then I can't see your healthcare expenditure ceiling really rising much over time, which gives you a problem. So the biggest take-home message that I have in terms of the impact that demographics have on you is because healthcare, quite appropriately in an aging society in particular, is funded by the public sector, because that probability of becoming ill is getting closer to 1 and the private sector won't fund it, is that you're going to be facing higher and higher constraints to fund healthcare expenditure through this public source. Here's the debt. On this side is just saying that not only is debt rising, but this bottom part here says that most governments are spending more than they're taking in, so they have to rely on debt to make up the shortfall. Spain's doing worse than most. So your tax base is falling. And then, of course, you might think, well, actually, what's happening by taxes in terms of the health expenditure within a country? And what we see is happening both on the public sector, the budget ceiling's getting constrained. In the private sector, if we take the USA as an example of the private sector in terms of how it might fund, about 45% of healthcare expenditure in the US comes through private insurance. You can see that these are monthly payments for private insurance, right? And they're quite considerable. Here we've got the average annual premiums on the y-axis against the time frame on the x-axis at the bottom. And you can see, if I hadn't moved it so quick, you can see these are premiums for single coverage at the individual level, family coverage. They've been rising over time. They've been rising enormously over time in the private sector. And the private sector has found that as healthcare expenditures increased, healthcare insurance has had to increase to cover these expenditures. And mapped against the last graph in the last slide, which shows the average annual premium rise from 1990 to 2024, is the median wage for the US. And that y-axis on the second graph here moves between $330 and $400. So again, if we squashed it down, it would just flat line. Median wages haven't been rising as fast as the premiums. On top of all of that, so we've got income generating some of the expenditure growth. We've got technology generating a lot of the expenditure growth. We've got insurance generating some of it through increased coverage. On top of that, a recent OECD report says that approximately 1/5 of healthcare expenditure in any healthcare system is inefficient. And they rest that claim on the fact that, for example, there's huge variation in treatments across countries and across populations, and that there's inappropriate use of healthcare, as well as fraud and error. If you've got a large sector in the economy, you're going to get fraud and error. But fraud and error is lower than the overall inappropriate use. The traditional approach to try to, in an insurance scheme, try to push some of the financial risk onto others is to say we're going to have co-payments, or we're going to pass some of the financial risk through to the individual patient. That doesn't work particularly well, and in fact, because we've got a very inelastic utilization of healthcare, it means that even if I pass some co-payment onto the patient, it's not going to have very much impact on the utilization, the volume of use of healthcare resources. So I can increase your out-of-pocket payment by about 10%, but I'll only see a drop of about 2 or 3% in utilization, and therefore overall expenditure still keeps going up. So what we've also seen globally is a rollout of the financial risk pushed forward to the providers. So the providers now are taking a lot of the financial risk away from the insurer, whether it's a private or a public insurer, and one of the main ways in doing that is through the reimbursement system within the hospital sector. And in the hospital sector in 1988 in the United States, the big social insurer, which covers the insurance for the elderly, Medicare, was going bankrupt, so they introduced a system where they said, okay, we're going to code all hospital outputs into treatment condition pairings. And these treatment condition pairings were called diagnostic related groups. And these DRGs were paired across the treatment that you get and the condition, the medical condition. So for example, if you had a heart attack, they'd pair all the treatments with the heart attack condition. And that DRG would then form the basis of the hospital output. And then Medicare said to everybody who was providing DRGs in the hospital sector, you give me your average costs. You just tell me what your average costs are. And then the reimburser would reimburse at the average of that spread of average costs. And therefore, they'd be saying, if you're inefficient and you're spending too much on this condition, you're going to lose out because I'm only going to reimburse you at the average of the spread. If you're efficient, you're going to make a surplus because I'm going to reimburse you at the average. And they play that reimbursement over time so that the variation shrunk and the mean went down, so that eventually hospitals were only being reimbursed for the average cost of their treatment. So that's one way in which they've pushed the insurer has pushed the financial risk onto the provider. The other way in which they've done it is they've given reimbursement attached to quality targets, and increasingly they're setting quality targets for physicians and saying that if you don't hit these quality targets, you're not being reimbursed. That's happening not only in the US, but it's also happening in the UK and other countries. Scandinavia and the Netherlands are being forced to hit, the providers are being forced to hit quality targets of care before they get any reimbursement. In the UK, for general practitioners, these quality targets now account for about 25% of the reimbursement that a general practitioner gets. What we're not particularly, if you were buying private insurance, you'd get a contract, and the insurance contract would tell you what you're covered for. If you move, because you've got an aging population and because the probability of getting to any disease gets close to 1, so you don't have private insurance coverage, you move to social insurance. What we're very bad at doing with social insurance is showing what the coverage, the insurance coverage is going to be. That's changing, however, as we see more and more health technology assessment agencies come into play, where these agencies put out clinical guidelines to say, this is the standard of care that we should expect for an average case. And also, do new technologies provide value for money in providing cost effectiveness for new technologies coming into play within the healthcare system? So the health technology agencies are really acting as part of the insurance scheme to define clearly and more explicitly the coverage that the population can expect. Lastly, what else does aging affect? Well, the aging in the population obviously has an impact upon the workforce. And it's said that already there's a shortage, according to the WHO, of about 1.8 million healthcare workers in Europe. And 1.8 million is about the number of physicians that work in Europe. So it's a fairly large, considerable healthcare shortage. Currently, about 20% of US physicians are over the age of 65. Around 33% of physicians in Spain are in the age bracket 55 to 65. So about a third of your population of doctors are going to be retiring in the next 10 years. All of that's putting pressure on, and it holds for the rest of Europe as well, all of that puts pressure on shortages within the healthcare systems within any country. Germany's probably the worst in the sense that it's got the highest share, about 36%, just over a third of the population's age between 55 and 64. And that's going to be leading to a shortage of physicians moving. This is only for physicians. The position's even worse for nurses. Not only that, remember I said that your workforce is shrinking, right? The ages 25, the proportion in the age 25 to 64 is shrinking, so the opportunities for that workforce to go elsewhere are improving. So the labor shortage within the medical workforce is also under pressure from growing opportunities elsewhere. It seems I've finished. Hang on, I can get to the conclusion, I think. I just skipped the last slide. Yeah, so I gave you the conclusions at the beginning, right? So they've not changed really. Healthcare expenditure per head continues to grow, and it continues to grow faster than GDP, national income. So the sector's growing. We're spending more on healthcare, and that's as it should be. As we get richer, then we'd expect to spend more on healthcare. Aging per se isn't having a hugely direct impact on that. Aging per se is accounting for about 5% of the increase in the growth in healthcare expenditure, because most healthcare expenditure is still in these last 2 years of life. The multimorbidities which are growing, and are growing particularly across a younger section of the population, are treated in the less expensive parts of the sector. Primary care and pharmaceuticals in particular are dealing with them. The fact that the population is aging is having a huge impact, I think, on healthcare, and will continue to have a huge impact on healthcare, because your tax base is shrinking. The number of people who are paying taxes is shrinking just because you're aging in your society. And that's happening across Europe. As the tax base shrinks, it means you've got less money to spend on public sector services. You've got more competition across the public services. Healthcare expenditure is going to have more and more bite put on it in terms of the rate of growth that we see. just at the time when the demand is increasing because of that direct influence of an aging population. And on top of that, the aging demographic itself is going to make the workforce shortages even more severe, because the opportunities, particularly for nursing, porter staff, administrative staff, are going to be greater. So I think aging does have an effect on healthcare. The direct effect isn't immediate, isn't huge, but the tax funding base is really going to bite in the next few years. So thank you for bearing with me. I'm sorry I've gone over time a bit.
Thank you very much, Alistair. If you can take a seat over here. Many thanks for providing this fascinating overview of the situation. We got about 20 minutes, and I've been told that we have to leave the room promptly before 8:30. So I have a series of questions, but if anyone wants to ask the first question to Alistair, please raise your hand. Yes, so please go ahead. Yes, wait for the microphone, please.
Thank you. Gracias. I have two questions about the slide with the population projections. One is, does it consider the migration rates, the net migration rates? And the second is, which is the order of the uncertainty? Because the projections are far away in time. So uncertainty should be growing, but I don't know if it's small or big or... Thank you.
What was the second part of the...
The second part is about the uncertainty of the population projection, because they are far away in time, so uncertainty should be growing or diverging, and I have no idea, so if you can give an order of magnitude or something, it will be... And thank you so much for a great chat.
So the figures do include net migration. So the workforce takes, I'm going to take this off because I'm getting some feedback, if I can. We have to undress.
You need the microphone.
Yeah. Yeah, anyway. So, sorry, the data do include net migration figures, so the hump of the working population, which is where the vast majority of migrants are lumped or show up in the data, they're included in that. So migration isn't going to help you greatly. Actually, unless the rates increase even further, right? Then inward migration increase even further. The projections, unless mortality rates really change fast, so unless life expectancies change really fast, which does happen, it can happen within it's happening in the United States, for example, where the life expectancy in middle ages in certain groups of the population is really plummeting. And they're plummeting because of what's been referred to as deaths by despair in the middle age group, of illicit drugs deaths, suicide deaths, and alcohol-related deaths. So we've seen the death rates plummeting in the middle age and the white non-Hispanics over a 5-year period to such an extent that it's taken 2 years off life expectancy on average across the population. So there's been a huge plummet in life expectancy. So it can happen, but unless that happens in Spain, and or other European countries, and there's very little evidence that it is happening, I think that the projections will hold up because they're based on this idea that life expectancy is increasing, albeit at a decreasing rate.
Okay, thank you. There was a question right behind.
Yes, hello. Thank you very much for the talk. And it was, for me, striking what you said about the Spanish elder population, that we had a very high life expectancy, but not that high healthy life expectancy. That was surprising. I didn't know. Why do you think this is happening?
I don't know for sure. I think you do have high rates of obesity. It might be something to do with comorbidities that come with obesity. So that might explain it, but I'd have to look at the epidemiological data in much more depth to try to explain it. These are official figures, though. They do come from Eurostat, that their healthy life expectancy is 64. Now, they take the data on morbidity from all sorts of sources, including self-reported health status. So it may be that you're just more pessimistic about your health states than others as well. But some of the morbidity statistics are from objective measures like diabetes, rates of diabetes, obesity, cardiovascular morbidities. So I don't know. I'd have to look at the data more. But it is, to my mind, true in as far as it's an official figure. You've got one of the lowest healthy life expectancies in Europe.
Mm-hmm. Any other questions coming from the audience? Yes, please.
Gracias por la charla.
Thank you. Thank you so much for your conference. It was extremely interesting. And it was extremely interesting. And this is a problem that has multiple causes. And you pointed to many parameters and many things that are having an influence in the amount of health spending, wealth, aging, technology, all these problems that we're seeing. But I don't see the solutions. What is the solution? I didn't find any solution in your conference. I know that is more difficult. But what can we do? Because it's not a good idea to increase taxes. We shouldn't increase public debt either. So what can we do? Do you think there is a solution or a way forward? At a micro level, perhaps, in provision. For example, the role of primary care, perhaps that should play a more important role, or adjusting the expense, or perhaps questioning many technologies. I don't know whether they all work or if they're all desirable, these technologies, or if they all improve health indicators or the way hospitals work. Don't you think this is a time to challenge all these things?
Yes, absolutely. I think that it is a time to challenge them. There's a couple of solutions, I think. The first one is, as I said, it seems to me to be absolutely correct that most of the insurance comes through the social insurance rather than private insurance because of just the actuarial calculation doesn't make sense, right? So you have to spread the financial risk across the whole population. But once you move into social insurance, as I said, we're not very good at saying this is the benefits package that we're providing. So I think we have to get more explicit about what it is that the social insurance is going to provide, especially in countries like Spain with your 17 autonomous regions where you've got vast variation in the type of delivery of healthcare that's being delivered to your population. So healthcare technology assessment agencies have to say, look, these are the treatments that we're going to provide as a social package. Now, how do you justify these treatments? Well, you have to do that through clinical evidence. And unfortunately, clinical evidence has all sorts of problems with it. To say whether a new treatment is worthwhile, generally you'd rely upon the gold standard of a clinical controlled, randomized controlled trial, a clinical trial. But most clinical trials have entry conditions, so they try to see whether a treatment's working by abstracting out all comorbidities. So if you get rid of the comorbidities in the population that you're looking at, They're generally a younger population compared to the more heterogeneous population that would be in the treatment population. So clinical trials will give you some evidence, but not a lot. So then you have to do some modeling, statistical modeling. And then the modeling might include some cost effectiveness modeling to see whether the new treatments are providing value for money. So before even I get to that point, I'd look at the 20% that the OECD, 20% of expenditure, which is said to be inefficient, okay? So you might try to get inefficiency out of the system, but then on top of that, I think we have to become more realistic as a population as to what it is that our healthcare tax money is buying in a benefits package. And that benefits package has to be led by evidence. So I think that's one thing. The other thing that is happening, all of the reimbursement financial shift to the provider, that reimbursement movement through the DRG reimbursement and the quality targets, these are all relatively new. So it may be that they'll move us towards a more efficient system, but really we're still paying for processes. We're not paying for health as such. Within the National Health Service in the UK, there are about 15 million inpatient episodes every year in England, and about 10% of them are surveyed to see how much better their health is before the treatment and after the treatment. And they're currently looking at ways of trying to add reimbursement packages into that improvement in health. So again, I think improve the health packages, that will adjust people's expectations about what they're going to get. It also might standardize care, so there is a cost to it. So look at the packages, look at the evidence as to what does work and what doesn't, and stop doing what doesn't work. And then maybe try to relate the payments to improvement in health rather than just the processes themselves.
Yes, over here, please.
I think you forgot one aspect that it's, I know you don't believe in that, but prevention and living healthier longer is a big factor that is a pending, una asignatura pendiente. Vivir más,
living more but better, so as not to, she's saying living more but better, a healthier life. That will reduce the spending. We have to change the paradigm. But prevention is really important.
I agree with that. Obviously, if you've not got very good, healthy lifespans, then improving your health is something as an individual you should do. The difficulty, of course, is it's very difficult to get people to change their behavior. Stop smoking, better diet, go and exercise, ruin your knees, you know. Yeah.
Okay. Yes, over here.
Hola.
Hi, I wanted to ask you, I know this is not the subject of the conference, but do you know if it is more, if the public system is more efficient than the private system, or perhaps a mixed system is the best? I don't know. There are many differences in the different systems in the different countries. Do you find one to be more efficient than others?
So it's all about insurance, so either it's private insurance or social insurance. It's certainly true that the private insurance administrative costs are much higher than the social insurance in general administrative costs. They're about roughly 12% of expenditure in the United States for the private sector, whereas in the UK or in Spain, they're around about 5%. And that's partly because the social insurer, if it's a tax-based system, doesn't have to work out all these probabilities, right? So it doesn't have the actuarial calculations. It doesn't have to get all the risk factors and then chase people for the billing, and it does it through the tax system. So private insurance tends to have higher administrative costs. However, it also tends to have better information on costs, the private sector, because they're more focused on being leaner. So I think there's things to be learned from the private insurance sector as well. What I think probably is going to happen is that if you have a social insurance system which provides certain healthcare package, and as that package becomes more explicit, as it is doing in the UK, for example, through its Health Technology Assessment Agency, then you may also get supplementary private healthcare insurance for those individuals who want to have maybe a higher quality of care or a different quality of care. So you're trading off the homogeneous package for heterogeneous risks against heterogeneous preferences. What you don't want to happen is what you've got in Spain, where you've got a universal healthcare coverage through the social insurance system, but a number of individuals carry private insurance so that they can get diagnosed in the private sector and then jump over to the treatment in the public sector. So that's just using private insurance in a way to get quicker treatment in the public sector because you're carrying private insurance. And I think that's a misuse of resources, so you'd want to regulate any supplementary private insurance much more strongly.
We have time for just one final question over here, please.
Thank you so much for your conference. My question is on whether we have information of how migration affects this spending, health spending.
How migration affects it is generally a good thing. Migration is generally a good thing for two reasons. The first reason is that migrants tend to be in the working age population, so as long as they're in the formal labour force, they're paying taxes, so that's a good thing. So they're contributing to your system in terms of revenue. And the second reason is that they tend to, up until now at least, migrants have tended to return home after their working lives. So they make their money and they go home. So they're not a draw on your health system either. So migration tends to be a win-win, at least until now. The patterns of migration might change as people come in earlier and lay down roots and have families. But as long as it's still contributing to the tax system, I think it's a good thing. I.e., they might not return home, and therefore draw in old age on your welfare state. But as long as they're paying taxes, I don't see that as a bad thing.
Well, thank you very much, and thank you very much, Alistair. I had a question, but I'm not going to ask it, which is you're describing a time bomb. I was going to ask, how long do we have until we start seeing systems collapsing, but please don't answer.
Up until 2040, it's very easy, because that's when your social, unless you start paying more taxes, and I'd say tax the rich.
But
we're all rich here, by the way, so it's you I'm talking about.
We heard that there's no more appetite for taxes. But anyway, thank you very much for a very interesting presentation. Thank you all for coming. Muchísimas gracias y espero que sigan viniendo a las próximas conferencias.
Thank you very much, and I hope you will attend future conferences. Thank you.